All right, so I'm going to mix it up a bit. How about we start talking about the newly diagnosed data? Cesar, what do you think were the most exciting studies, whether it's in the transplant eligible or ineligible setting? All of us have been, waiting for the GRIFFIN and the Casio data to mature and maybe get some more information from Forte. But there were more trials in newly diagnosed that, with ISA quads, that also, came out. So go for it.
So let's start with transplant eligible, and there was updates on the Griffin study, and they presented data on updates after 2 years of maintenance therapy, and their data showed that after induction therapy, MRD using VRD plus DARA was 22% versus VRD alone 8%. That was just after the induction, which was one of the primary endpoints of the study, MRD as a response. In terms of the depth of response, 72% achieved a VGPR on the DARA arm versus 56% in the non-DARA arm, just VRD alone. That's in induction. But the interesting thing with the data now that it's matured and we have 2 years of maintenance therapies, that we're seeing depth of response. And these arms had a little bit more of a widening gap there in terms of response. VGPR better for the DARA VRD arm after the 2 years was 96% versus 79% in the VRD alone. But in terms of MRD status, we see that at 64% of the patients that had DARA as part of the regimen achieved an MRD negative status of 10 to the minus 5 versus 30% of the population that had just VRD alone. So that's interesting. We're seeing a deeper MRD response in the population that received DARA. Hopefully this will translate to prolonged PFS. We still don't have, this study was not powered for that, so we don't know if that's gonna help in the long run or not. But this sets the ground for the PERSEA studies, which is the phase 3 that's actually gonna be looking at this important question about PFS and if DARA is really adding survival and PFS in patients if we do it up front and as part of maintenance. That's one of the interesting studies for transplant eligible. There was also another quad that was presented, the GMMG. That was actually using ISA VRD versus VRD. And they were then taken to transplant and then randomized to maintenance therapy using ISA and lenalidomide alone, lenalidomide versus lenalidomide alone. And at this point, the data that was presented was just following induction. We still don't have the data of post-transplant and the maintenance therapy. But in terms of response rates, people who received ISA with VRD after the induction achieved 77% of these patients achieved a VGPR or better versus 60% in the people who only received VRD. And then if we look at MRD status at the end of induction, 50% of those who received ISA with part of the induction achieved MRD negative status to 10 to the minus 5 versus 35%. So in terms of response rate, we're seeing very similar responses with or without ISA, to be honest. And that, I don't know if it's because the data hasn't been cleaned up completely or not, but 60 to 77%, it's not a huge gap, but it is definitely a trend there. But MRD status, we're definitely seeing a significant difference when we add isatuximab. It's going to be interesting to see how this is going to translate post-transplant and post-maintenance. And at the same time, this is an interesting study because unlike GRIFFIN, where all of the patients received DARA as part of their maintenance or LEN, they didn't cross over or get re-randomized after transplant. This study is randomizing post-transplant. So we will also have the answer of whether there's a benefit of doing a monoclonal antibody therapy post-transplant if they didn't receive it as part of their induction.
Yeah, I think, Cesar, I'm going to go to Shyam, but I have 2 comments there. So, we have the SWOG 18-of-3 study that's randomizing patients to DARA-LEN versus LEN in the US cooperative group setting. We've got the ORIGA trial as well. the critique for Cassiopeia had been, maybe we are not seeing the signal of DARA maintenance in the patients who got DARA VTD because you're giving DARA every 8 weeks, and that's not how we
Yeah.
utilize this in other studies